Good evening, everybody. I'm Rahul Chobe from Anaesthesia TV. For today's webinar, we are live now. I'm handing over this session to Dr. Madhuri Dadke, Madam. Madam, please give introduction to the panelist and the speaker.
Yes, good evening. Welcome to the PRAC Live webinar series. Frailty is a well-known entity. We have been applying it all this time, but without a standard index for it. We have been using instinct and experience to identify frail patients. But this is subject to observer variability. So we need a specific index for it so that we can prehabilitate, that is, intervene on frail patients, optimize physical function and psychological state before elective surgery. We are lucky to have Dr. Aditi Malpani to speak on this topic. She is a physician at Sancheti Hospital with specialization in geriatric medicine. Please proceed, Dr. Aditi.
Just a moment. I think there is a connection problem. Just wait a few seconds. I think this is for the first time that we are discussing this issue. Frailty is relatively a new topic for all of us, I think. I think Dr. Aditi is getting connected to the network. Till then, I'll just continue the introduction. This topic has been in discussion for last few years, but I think anesthesia field, not much importance has been yet given, and people are not aware of this concept yet. And this is the reason why we have invited our physician and somebody who specializes in geriatric medicine to speak about this topic, so that we'll have a wider idea and better understanding of the concepts which are concerned in this. As you all know, the longevity of the whole population is increasing. So we have to be ready to handle older and older patients as the time goes by. And these patients may be in the 8th decade or the 9th decade of life, or sometimes even the 100+ years. We do get patients with fractures, and we have to be ready to handle them. And to understand whether these patients can be subjected to anesthesia and surgery. And it's a difficult situation, because these patients will always have some comorbidities, or they may be non-ambulatory, or they may have some cognitive dysfunctions. So frailty, when this topic was started in about 2014, this may prove to be a very good tool in the hands of the perioperative physicians, either the internal medicine physicians or the anesthesiologist, who are concerned in taking care of such patients in the perioperative period. This may maybe change our view in looking after the patients in the preoperative period, as well as managing them intraoperatively under anesthesia, and even managing them in the post-operative period. And sometimes that will decide whether the patient needs any special care perioperatively, and also what may be the how easy it will be to discharge them, or will they need any special care in the post-op period. I think Dr. Aditi is back online, and let's invite her to start her talk. Dr. Aditi. Unmute.
Good evening, everyone. Today I'll be talking about frailty in surgical patients and why it is important, because it can lead to some post-operative complications. So in the following slides, we'll discuss what is frailty, why it is significant in the surgical patients, how it is diagnosed, what are the various scores and scales of frailty, what can be the adverse outcomes post-surgery, and how that can be prevented, or some treatment recommendations. So defining frailty, it is a syndrome of multisystem physiologic decline because of the loss of biologic reserve, which is seen as the patient ages, and also there's increased vulnerability to even minor stresses. Now, minor stresses can be just a simple urinary tract infection, or some minor surgeries, or the psychological stress. So why it is significant and why we need to identify these frail patients, especially before the surgeries. So as we talk about the frailty, we see that as the age progresses, the prevalence of the frailty increases. And so as the risk factors, or whatever the comorbidity factors are present, they all lead to some complications or adverse outcomes post-surgery. But if we compare, for example, a patients like of 60, 70 or 80 years of age, and now we are more seeing even the 85 and 90 years age group patients coming for surgery. But all of them, or all the patients of same age, again, they do not have the same risk. If we take 5 patients of 60 years age, everybody would have the different comorbidities, different risk factors, and of course the frailty stages also. So why discussing frailty or identifying and scoring is important to prevent the disability. Also, frailty leads to falls. Very commonly in the elderly, hip fractures are seen, which again increases the hospitalization, and in some patients even the mortality. So with the hospitalization and fractures or any kind of disability, obviously the health resources are used for, and if there are some post-operative complications happening, then the length of the stay in the hospital increases, ICU stay increases if the patients are on ventilation. So broadly, we can like categorize patients in early frailty when we check patients pre-operatively, or even if the patient is not for surgery. In the OPD also, if we see, the clinical appearance might be frail, the patient will have poor tolerance to stress, but these patients, they don't have any kind of disability, or probably they can recover if there is any amount of little bit stress, they can be recovered from that. Then late frailties, like of course there will be poor tolerance to stressors, but then these patients are very slow to recover from the surgery or whatever illness they are facing at that moment. And these patients are prone to disability. End stage frailty will define as the severely frail, or the patient who has undergone weight loss. Low strength. Now, low strength, it can be, there are indices to measure the strength, or on the history we can ask for their routine activities. So we'll know about the low strength. Then how much, if the disability, any kind of disability is present, so patients are dependent on the family or the caretakers. So eventually the high frailty, it will lead to risk of mortality. So perioperatively, always there is a physiological stress to the body because of the injury itself, because of the trauma which might have happened, or the whatever condition for the surgery for which the surgery is going to take place, and also the psychological stress. So identifying these vulnerable surgical patients is very important, because this will give us some idea about the anticipating, or we can anticipate some post-operative complications. We can risk stratify these patients, and when we know this subgroup of the patients, we can have some medical, surgical, or anesthetic management can be modified, can be changed or implemented before the surgery, intraoperatively, and of course post-operatively. And also defining how much the frailty index is will also, I mean, as it is, because the frail patients, they take more time to recover post-surgery. So the rehabilitation part is very important. So when we can stratify these patients, or when we identify these frail patients, we can also recommend for the rehabilitation process. So these are the common adverse outcomes which we usually see after the surgery, and some of this can be definitely prevented, or at least we can timely intervene to avoid the mortality, the following risk of death. So these are the cardiac, which include the myocardial infarction and the arrhythmias, then the DVT and the pulmonary embolism, pneumonias, renal insufficiency, cardiovascular events in the form of stroke or TIAs, urinary tract infection, which can, if go unnoticed or not treated in time, they can lead to sepsis, then surgical site infections. And if the patient is has developed some kind of infection or complications, there is increased length of stay in the hospital and mortality. So in this diagram, it is very nicely explained how, because of the aging and the sarcopenia, it leads to frailty. So when we talk about a frail patients, it's not only the comorbid diseases or the chronic diseases. There is an aging process in that, there is sarcopenia, everything this contributes to the frailty. And eventually, if the patient becomes disabled, the dependency on the caretakers or the family. And if the patient is frail and he's subjected to some kind of acute stress, it can be any kind of illness or any injury or surgery, then we can anticipate some of the adverse outcomes or complications which can happen post surgery. There are two concepts of frailty defined, on which all the scores and indices are made. So first is the physical or the phenotypic type, or the concept of frailty. In this, they have defined it's a pathophysiological process. So there's decrease in the physiologic function of the body. There's breakdown of the homeostatic mechanisms between all the systems, like the neurosystem, immune system, endocrine systems. And all these things, they happen with age. So biologic alterations which happen because of the aging are described in the phenotypic concept of frailty. The other concept is the deficit accumulation. That is, whatever the psychological, physical, or social factors also sometimes, which the cumulative burden of all this, which can lead to the frailty. This is little busy slide, but I will explain you. It's very simple. As we have talked about the phenotypic and the cumulative burden, which contributes to the frailty. So in this, they have divided the functional capacity into the health condition of the patient. So when the health condition of patient goes down, for example, when there is infection, there are some injuries, or any type of cardiorespiratory disease, or a simple thing as inability to prepare the meals, so that will lead to undernutrition. So this will again contribute, or it is a contributing factor to frailty. Then second is the impairment of the body structure or function. Now this can be because of very commonly in the elderly seen as the impaired vision or the hearing, or sometimes cognitive impairment we see, psychological factors leading to depression or some family problems. Then uh, third thing is the decreased mobility. Now this could be because of the gait problems in the elderly, which are again commonly seen. Then some neurological problems like Parkinson's. There can be some traumatic events, injury, fractures, which can again lead to decreased mobility in these patients. Also, sometimes environmental barriers are there. Very commonly, we see patients coming to the OPD, or sometimes we see pre-operatively, and when we inquire them about their mobility, most of the times the environmental barriers, it's like they are staying on some third or fourth floor, or they are staying in a remote places from their not because of some disease or some disability there is restricted mobility, but probably because they cannot climb down or it's not easy, we see this activity limitation. Then fourth, they have described as some social barriers or some family problems. So these elderly, they participate less, they have decreased efficiency, or they are dependent on the family. Then again, fifth point is the environmental and the contextual factors. So this would be again, there would be some social problems or service related problems, lack of service coordination. So all these things cumulatively, they will, I mean, the cumulative burden will increase, and that defines the frailty. So now before the surgery, or even when we evaluate a patient in the OPD, IPD, along with the frailty index, it's very important when we talk about the geriatric patients that we do their complete assessment. Only assessing about the frailty is not going to give us about all the problems. So there is CGA, which is very commonly used, and it's very best method to evaluate the health status. That is a comprehensive geriatric assessment. So in this, we talk not only about the functional status and the cognitive status, but also the emotional status, nutritional status of the patient is defined. And there are some geriatric syndromes like the delirium, the visual problems, the false risk due to osteoporosis, some hearing impairments, then the polypharmacy. These are all very common problems which are seen in geriatric age group. So assessing each one, and each one has their own indexes to define, like the functional status have very commonly used are the Barthel's ADLs, which is used to assess the functional status. Nutritional status would be defined on the history or some blood parameters. Cognition would have, they have many scales and scores to define the cognition status of the patients. Also, if the patients have dementia or any other cognitive impairment, so as per their cognitive impairment, there are scoring systems. For the comorbidities, of course, we have scoring systems, and also to risk stratify the cardiac and the pulmonary risk. Polypharmacy is very important to identify in these geriatric patients, because there can be many drug interactions, and even subtracting or adding a single drug can lead to serious complications. Or probably a patient is given a prescription for one problem, he develops some kind of side effects, he is to tackle those side effects, he's giving a second prescription. This is very commonly seen. So this polypharmacy should be strictly avoided and taken care in the geriatric patients. So in short, there is
We are just checking. Sound is not coming. Just a moment.
There is some sound issue.
Yeah, Aditi,
Hello. I think there is some technical issue, and I think the Aditi has. Okay, she's back online. You need to unmute Aditi. Hello, Aditi needs to. You need to unmute. Aditi, you need to unmute. I think there is some technical problem at the moment.
So let's continue the panel discussion. Today we have Dr. Bharti Ade, Dr. Lakshmi Mandvikar, Dr. Mamta Sadre, and Dr. Sandeep Devan as panelists.
Okay, let's wait. Let's check.
So we were talking about the diagnosis of frailty. So when we ask about the history, we can ask about how much fatigue the patient gets, like on the routine activities, whether there is some inability to perform the physical activities which he or she has been performing every day. How are the energy levels? Then in examination, apart from the general examination, which we would definitely do, the importance should be given to the cardiovascular and the neurological examination. Now, there are some objective markers which we routinely do, like the hemoglobin, the protein levels, the liver function test, the metabolic panel in these preoperative patients. There are some biologic markers suggested, but these are not really feasible and individually significant to score the frailty. BMD is again important when the patient comes to us with some hip fractures. Then evaluating their gait speed and the muscle strength. So this will indicate how much there is low muscle mass or impaired muscle function. So we can assess the sarcopenia in these patients. Now there are various screening tools for the frailty in the perioperative setting. So depending on the observational or the self-reported questionnaires, these are few of them. I will discuss in detail one of the observational tools, that is Fried Frailty Phenotype, and one of the self-reported questionnaires, that is the Frail scale, in detail. So this is Fried Frailty Phenotype. In this, 5 criteria are taken to assess the frailty status of the patient. First criteria is the weakness. So weakness is measured by seeing the grip strength of the, and there are some props also which can be used to calculate this grip strength. Then exhaustion is the second point. So this is self-reported poor energy or endurance by the patient. Then shrinkage, that is the weight loss. So unintentional weight loss more than 4.5 kg in last 6 months to 1 year. Then slowness of the activities or the slow gait speed. There are again various parameters to measure the gait speed. Then also low level of physical activities. Now this can be measured by the kilocalories expended, like expenditure in last 1 week, or and which differs in the males and females. So now depending on these criteria, if we have 1 or 2 criteria present, the patient can be labeled as a pre-frail, and if 3 or more criteria, then the patient can be labeled as a frail patient. This is another clinical frailty scale. So this we can easily use in the pre-operative setting. The first are the very fit patients. Then second is well. So in these, there are no active diseases present, but when we evaluate, these patients are less fit than the category 1. Then third is the well, but they have comorbidities, but there are no active any disease symptoms, or very minimal disease symptoms which can be very well treated. Then fourth group is an apparently vulnerable patient. So these have sorry, these have comorbidities. They complained of symptoms of fatigue or low energy, and also gait speed is low, or in general being slow. So this is the group when we really need to identify, because these patients then they progress towards the frailty, progress towards the limited their functional dependence. Uh, Fifth category is the mildly frail. So in this, patients are dependent for their activities of daily living, but they can perform some of the activities. Moderately frail, they would need help with the both ADLs and the IDLs. Severely frail, these people or these patients are completely dependent, like we see in advanced cases of malignancies. There's a third, this scale as the fatigue, resistance, ambulation, illness, and loss of weight. This is very easy and easy to use in the preoperative patients. So we can ask in the history about the fatigue, we can ask about the resistance, and the easiest is like, can you climb one stair? So do you get dyspneic or any other symptoms like giddiness or gait problems happen? Then you can ask about how much the patient is ambulated or mobile every day. Can the patient walk one block, like roughly 200 or 300 meters? Then how many illnesses are present? So if more than five, that would be very significant. The illness is mainly pertaining to all systems like the hypertension, diabetes, lung disease, asthma, arthritis, stroke, kidney diseases, and the malignancies. And you inquire about the loss of weight if it is more than 5% of their weight. So if three or more parameters are present, patient can be labeled into a frailty criteria. These are some other indexes which are used in practice, or most of them for the research purposes. So there are the Edmonton Frailty Scale. Then there is a surgical risk calculator which is used, modified frailty scales. I won't go into the details of these. Now coming to the perioperative assessment and the management. So along with the frailty index, when we completely or comprehensively assess the any geriatric patient, so it has to be some history, and a part of our examination, it has to be focused as per the geriatric patients. Then after the history and the examination, all the preoperative diagnostic tests we do, these include the lab, the radiological test, the sonography if required, ECG, and in few patients if the BMD is indicated. So basically before the surgery, we need to optimize all these medical conditions, whatever the comorbidities patients has. So those all conditions need to be corrected. We need to broadly check the hemoglobin, sugar, electrolytes. These can have direct impact on the surgery or during the perioperative period. Also control the blood pressure along with the sugars, and any kind of infection. It might be chest infections, abdominal or urinary tract infections. And importantly, if we can uh, do our assessment very correctly and score the patients well based on the frailty and other risk factors also, when we define mainly the cardiac and the pulmonary, so we will be able to predict some of the blood losses or the fluid shifts which happen during the perioperative period. So preoperatively, apart from the disease evaluation, there should be a cognitive ability and capacity should be evaluated. Patient should be screened for depression, because only operating the patient or doing a surgery is not going to help in the recovery period. There has to be family, social support. Patient himself has to be very proactive in doing the post surgery or post operative rehabilitation process. Then we need to identify some of the risk factors which can lead to delirium, because delirium is one of the very commonly seen complication in the post-operative period, and most of the factors are seen precipitating this. They can be definitely avoided. Also in this age, we should screen for the alcohol dependence or any kind of substance abuse or tobacco addictions. Cardiac evaluation, of course, the pulmonary assessment, the functional status should be inquired pre-fracture or pre-fall or pre-surgery. Nutritionally, patient should be assessed. Medication history is very important. As I had mentioned earlier about the polypharmacy or the routine medications, whatever the patients might be taking. You score the frailty as per whatever the scale has been decided to be used. Then the family and the social support system also should be seen. Now, these are some of the reversible factors which we need to correct pre-operatively, and this can be missed, or sometimes when we evaluate the patient pre-operatively, because of these reversible risk factors, our assessment also can change in 24 to 48 hours and on the day of the surgery. So, for example, the substance abuse like the tobacco addiction or the alcohol. So, if you see a patient on the first day and you see a patient on the third or the fourth day, definitely there will be difference in the cognition level, and there can be some other metabolic problems also. So these are the reversible factors, and this should be identified, which can be corrected before the surgery. Also importantly, because this affects the capacity of the patient, capacity to understand that the patient is going to undergo a surgery. Then depression or any other mental illness, if acutely has been exaggerated by something, they should be corrected. Thyroid disorders, they can be corrected. Delirium, of course, whatever the precipitating factors are there, that should be definitely worked upon and prevented. Any kind of infection should be treated. Metabolic derangements, they should be corrected. Hypoxia or hypercarbia because of any injuries or pulmonary problems, they should be corrected. Recent head injury should be taken into account, especially in the elderly patients when they come with the fall. There might be fractures in the upper limb and the lower limbs. The head injury might be missed sometimes because there can be no symptoms. There will be no vomiting, no headache. But subdural hematomas is a very common in the elderly population. Even if they have fallen 8 days back, or we should inquire about the falls history, because STH can lead to perioperative problems. Then intraoperative factors like the hypothermia, blood pressure fluctuations, the blood loss, or any cardiac event, this will again have impact on.
Yes.
Share screen.
Okay, so in the post-operative period, we need to correct on the from the day zero itself about the. We need to correct, give the good pain management. Also need to correct any gastrointestinal problems if the patient have, like the nausea, vomiting, because if this is treated in time, we can start the oral feeds or the rehydration of the patient in time post-operatively. We should take care of the catheters and the drains and remove them as soon as possible. Then discontinuation of the IV medication should be done in all elderly patients as soon as possible, because then this will encourage them to have orally, and if there is no nausea, vomiting, or any abdomen related symptoms, this can be definitely done. Very important is the early mobilization of the patients post surgery. The more they are in the bed, they feel psychologically and physically also very dependent. So early mobilization, especially after the hip fractures, is very important. This also promotes the personal independence for the patient, and patient has to be very actively involved in its own recovery. So when we talk about the treatment, as we have seen in the post-operative period, what needs to be done. So in all geriatric patients in the elderly, the treatment needs to be tailored to the particular that patient. So apart from the medications or the pharmacological treatment to treat frailty as such, there are no medications. We need to treat the comorbid conditions or whatever the present illness are there. The supplementations like the vitamin D, they can be given, or the osteoporosis is there, that can be treated. Very importantly, if the smoking, tobacco addiction is there, that needs to be stopped. The exercise and the rehabilitation process has to start on the day 0. Then vaccination, this wouldn't apply to the post-operative patients, but in general to the frail patients or the elderly patients, we need to take care about the vaccination also, like the influenza or the pneumonia vaccines. Then definitely reduce the polypharmacy if it is present. Adequately do the pain management, support the nutrition with the calorie and the protein. Assess the patients cognitively every day and treat as soon as possible. Very commonly, we see hyponatremia-like symptoms or the delirium-like symptoms in the post-operative period. And intervening all non-life-threatening conditions in time is very important. Lastly, the social support, the individual, family, and the community support is very important. So in treating these frail patients or elderly patients in the perioperative period after the surgeries, multidisciplinary approach is very important. And another a new concept, or maybe we need to really work on this, is a rehabilitation process we define in the post-operative period, but the prehabilitation process should start when there is some elective surgery or some surgeries are planned, when we know there's some kind of surgery going to happen in 2 to 3 weeks, in the following 2 to 3 weeks. So we should start this prehabilitation process. It essentially involves controlling of the any present illness, acute illness, correction of the comorbidities, psychologically supporting the patient, and also anticipating some problems which can occur, or family or social issues in the post-operative period. So right from the pre-operatively, this process can be supported. So frailty is a dynamic age-related process of deficit accumulation, leading eventually to complex systems. So coming to closer to the failure. So if we identify this and evaluate frailty or any geriatric problems in time, and if we can reduce the burden of this cumulative deficits, we can take away the patient from the failure. So of course we see the patients pre-operatively or in the hospital, but when we see any frail patients in the community, definitely the last option, that is what we should everybody try. And thank you.
Thank you, Dr. Aditi, for your fantastic and detailed presentation. So now we will move on to the panel discussion. Dr. Bharti Adhe, Dr. Lakshmi Mandvikar, Dr. Mamta Sadre, and Dr. Sandeep Diwan are here to continue with the panel discussion. So, Dr. Lakshmi Mandvikar, Madam, do you have any comments on frailty?
Okay, so nice presentation, Dr. Aditi. You have solved most of our queries. You have solved most of our queries regarding the frailty. Frailty has been recognized as an important risk factor for the development of post-operative complications and increased length of stay. As we know, the ASA score, the number of prescribed medicines, exercise tolerance of the patient, these are the useful predictors for the diagnosis and staging of the frailty. I just want to know, is there any role of application of smartphone technology in the diagnosis of frailty?
I think that see now the age is of digital technology. So I think we already have some apps which will be available, which are already available on net, and you can have all the parameters which you can. It's like a chart where you will be able to what I should say, give score to various factors in this Frailty scoring. So this is definitely available. Dr. Aditi, I have one question for you. Is there any difference between cachexia and Frailty, or are they the same?
Cachexia, essentially, we use this terminology where in the malignancy patients most of the times, or when there are chronic diseases. So it is essentially a catabolic process or a pathologic process when we define or when we say that the patient is cachexic. When we talk about sarcopenia, it is a low muscle mass along with a low muscle strength, and combined both that can be grouped under the frailty. So they are both these things are the components of the frailty.
Okay, so we can still have. I mean, when you talk about Frailty, do you mean to say that you can have say one patient who is very frail?
Yes, we can have these patients.
Yeah, because that has been a routine problem. We get the patients in whom there is no comorbidity as such, but when you look at the patient is definitely frail and fits into the criteria what you have just described.
Yeah, because the frailty, it will include not only the comorbid conditions, but the functional status, the cognitive status, then the muscle strength of the patient, the gait speed. There are many parameters which are included in the frailty. It is a cumulative burden, or you can say the physiological decline which is seen as per the age. So in the elderly patients or when the patient aged, it is because of the inflammatory process, the sarcopenia or the frailty, what we describe.
So since there is sarcopenia, should we be doing albumin assessment in all these patients in whom we see loss of muscle mass? And is there any role of replacement of albumin in these patients if they are coming for surgery?
All patients, I mean, we have seen patients who have absolutely normal albumin and still they going into the post-operative complications. So individually, only albumin wouldn't give us a complete idea about the nutritional status. It has to be correlated with many other factors. So just identifying that the patient has low albumin and replacing the albumin is not really going to prevent the complications. It might help when like on the day of the surgery or when there is expected blood loss or blood loss is there, that time probably we can replace it, but it won't really prevent any kind of complications.
Okay, so that clears up. Okay, now when we talk about the anesthesia issues for in patients who are frail, I think we'll have to keep in mind all the factors what you have just mentioned as part of frailty, like the loss of muscle mass, polypharmacy, the weight reduction, the various geriatric syndromes. I think we'll have to keep everything in mind, and that will affect the choice of anesthesia. So, Dr. Manvikar, do you have any preferences for the type of anesthesia you will like to give in these patients who are diagnosed as frail or pre-frail, what we call it?
I think Dr. Bharti is handling so many geriatric patients in our hospital. You are the better judge.
No. I think this involves everyone. Whoever is doing geriatric anesthesia or whoever is doing all the complicated cases in any hospital, whether it may be urban or rural setting, understanding the concept of frailty remains very important. I mean, as you all have understood that ASA grading is something different where you just focus on the comorbidities, and frailty is the functional capacity of the patient or the functional reserve that your patient may be having so as to tolerate the stress of surgery. So these are complementary things, that is the ASA grading and the frailty. And you add the role of polypharmacy in these patients, then you have a better picture when you assess these patients. So coming to the choice of anesthesia in these patients, you can do certain procedures under only GA. You can do certain procedures only under regional anesthesia. You can do certain procedures only under neuraxial anesthesia or certain procedures only under peripheral regional anesthesia or the nerve blocks. But nowadays, there is an increasing trend where you have a frail patient in whom you continue to, you want to give a light general anesthesia and combine with various peripheral nerve blocks, which will not hamper any neuraxial anesthesia or the structures, because many of these patients will be on various types of antiplatelets and anticoagulants. So you will be definitely avoiding the neuraxial anesthesia if the patients are on regular anticoagulants and antiplatelets. So the trend in many centers, especially the institutes, is that you go for very light general anesthesia in very low ultra short acting medicines in limited doses, maybe avoiding either muscle relaxants totally or go for ultra short acting drugs like atracurium or cis-atracurium and combine them with the peripheral nerve blocks so that your patient will be comfortable. You will be taking care of the oxygenation of the patient, because if you just give regional anesthesia in these patients, some of them can become disoriented or rowdy on table, and giving sedation in high doses to these patients, maybe in the form of benzodiazepines or ketamines or small doses of propofol or sevoflurane or whatever you can get your hands on, is very tricky, because these patients cannot tolerate all these polypharmacy, and your patient will definitely land up with postoperative cognitive dysfunction. To avoid this, it is always better to have a planned, very light general anesthesia combined with peripheral nerve blocks, in where you take care of the fluid management of these patients, the oxygenation of the patients, keep them warm in the theater, and at the same time, with your peripheral nerve blocks, you give them excellent intraoperative analgesia, give minimum doses of opioids, and continue the analgesia in the post-op period also. Thereby, the systemic analgesics are avoided or may be required in a very limited doses. And the second thing is, whenever you identify these patients who are very frail, the most important thing you should be doing for them is to make them awake as quickly as possible, ambulate them as quickly as possible, avoid catheterizations, start feeding them as early as possible, try to keep them in a very familiar environment or with their at least some of the family members with them, so that the post-operative cognitive dysfunction is minimized. Anything else?
So Madam has spoken very well about the light general anesthesia. Light general anesthesia. If we have a BIS monitor, it is ideal, where we should maintain a BIS of less than 45. That is maintaining a lower depth of anesthesia. because they say that higher depth will lead to cognitive disorders, dementia, and if it is also associated with a low mean arterial pressure during the surgery, it does add to the increased risk of post-operative morbidity and mortality. So if there are any more questions anybody wants to ask, we can continue. Sadari madam, do you have any
Yes,
opinion?
good evening, everybody. Thank you, Malpani madam, for such a wonderful explanation of the frailty criteria. It is really very helpful for proper counseling of the relatives and preventing morbidity and mortality, and proper optimization of the patient. My question is, how much it is applicable in remote areas?
Okay, madam, this is all these scales are very simple to follow, and it can be used by anybody, even in the rural setting or in the urban setting, because here we are trying to, we are trying to get the functional capacity of the patient, means whether the patient can manage their daily activities. Have they lost any weight in recent, maybe around 3 kgs in last 6 months? Have they been hospitalized frequently? Do they have anybody to take care of them? Can they get up and walk for a distance of about 6 meters on their own? And in how much time they can? Or can they climb a flight of stairs? All these are simple parameters. I mean, simple questions to ask. So anybody who is working even in the rural setting can definitely assess this. And there are different scales. So if you take, for example, the Edmonton's frailty scale, any score above 4 will put the patient as a frail. It may be intermediate frailty, and more higher scores will put him in the severe frail. So anybody who is practicing in the rural area can also label this, and this will definitely give a I think better point for counseling the family when you talk to the patient's family, because that will give you whether there are more chances of getting perioperative complications or any post-operative complications. Are there any chances that the length of stay in the hospital will be more, and whether the patient may need some institutional care or the nursing home care for a long time. So all these factors can be decided when you do the frailty scoring, and this can be easily done without any equipment, the special equipment, but just following a simple sequence of questions from the patients and the family.
Okay, thank you so much.
Thank you, Sadari madam, for your opinion. Are there any more questions to ask? Bharti madam?
Would you like to have any comments after all the discussions on the anesthesia part? Do you have any suggestions? I think geriatric population is such that you need a multidisciplinary management. You must have a good physician like Aditi who is there with you. So this is definitely a good discussion, and I think Dr. Madhuri can have some comments.
Actually, if we could apply this index much earlier before the surgery, 1 week or 1 month prior, it would help us, as she said, to prehabilitate our patients. And not just prehabilitate. If we feel we cannot, we have to take a call on whether to proceed with the procedure or not. Because we don't really want to do any harm to the patient. So we can apply this in the pre-surgical period. So I think with this we will wind up today's webinar. Many thanks to Dr. Aditi Malpani and to our expert panelists, Dr. Bharti Abbe, Dr. Lakshmi Manvikar, Dr. Mamta Sadre, and Dr. Sandeep Dewan. Thanks to Dr. Parag Sancheti for providing us this platform for the webinar. Rahul Chobai and to Dr. Ashok Sham. Thanks to our media team for helping us today. Thank you so much. Good evening.
Thank you.
Thank you, everybody. Sorry, I'm